What's up, everybody? My name is Brandon Hunter. I'm a board-certified pediatrician and ICU doc, and today talking about newborn jaundice. So this is an extremely common condition. Only 2% will have what we call severe hyperbilirubinemia, or something that puts them at risk of a bad outcome. What is that bad outcome? Well, it's something called kernicterus. So bilirubin causes yellowing of the skin. If that level gets too high, it can actually deposit in the brain, leading to negative neurodevelopmental outcomes for kids. So it is critical that parents understand what to do about jaundice and how to get appropriate monitoring and follow-up. So let's get right into it. So jaundice is a sign, which is yellowing of the skin. Scleral icterus is a sign, which means yellowing of the eyes. Both of them tend to indicate that the levels of bilirubin are high in the blood. We'll talk about that in just a second. The way to test for this is pretty obvious. You just look at a patient and see if they're yellow, but sometimes it can be kind of hard to tell. So one thing that you can do is actually just push on the skin, release it. So when the skin has blanched and the blood has flown out of it, it can sometimes be a little bit more obvious if the skin is yellow or not. So it's something that you could check on your child. So we said that jaundice means yellowing of the skin from high levels of bilirubin. Well, what is bilirubin? On the screen, I've shown a nice little graphic here. You don't have to understand all of it, but the most important thing is that basically red blood cells, which carry oxygen in our blood, when they break down for any reason, it eventually leads to the production of bilirubin, kind of as a byproduct. Bilirubin in the blood goes to the liver, where it processes it and then releases it into the intestines. And really, most of the bilirubin gets excreted in stool. You can imagine that if there are high levels of bilirubin in the blood, then eventually it will build up and cause deposits in the brain. And so this is exactly what we're trying to avoid. In infants, why do they have such a high rate of jaundice? Well, there's pretty much 3 reasons that have to do with everything on the screen. First, they often have more red blood cells and more red blood cell turnover than we do as adults. Second, the newborn's liver is really immature, so it actually can't process bilirubin as effectively as you or I could. And then finally, the gut has no microbiome, so there's really not a lot of bacteria in the newborn's gut, which normally processes the bilirubin. And so you can see here, a lot of the bilirubin then actually gets reabsorbed and has to be reprocessed by the baby, reprocessed by the liver. In general, the bilirubin levels peak around day 2 to 4 of life. For East Asian ancestry, the peak is a little bit longer, maybe 3 to 5 days. I've listed here on the screen some of the most common reasons that you would have increased jaundice or increased risk of jaundice or complications, but I'll focus on probably the 3 most common ones that you may encounter as a parent. So the first is if there's a birthing injury. Going through the vaginal canal, or sometimes if a suction cup has to be used to pull a baby out from the mom, then you can have what's called a cephalohematoma. This in and of itself isn't really a problem. It's essentially just a big bruise. But you can see from the graphic that there's going to be a bunch of red blood cells in here and blood just sitting there. Those red blood cells are going to break down, and so you can imagine that there would be more bilirubin that the baby has to deal with. So, increased risk of jaundice. You are also at increased risk of high bilirubin levels if there's a mismatch between the mom's blood and the baby's blood. The basic idea is that if the mom has antibodies that would attack the baby's red blood cells, then it would break them open and also cause more bilirubin to be in the blood. And then the final common thing that you might see has to do with breastfeeding. So number 1, I'm a pediatrician. Don't be deterred by breastfeeding because of these things. These are minor and you can definitely work through them. Breastfeeding is great for children. But the first is called breastfeeding failure or lactation failure jaundice. So this occurs when basically the baby is just not getting enough intake, and often occurs with breastfeeding. You can imagine that if there's not enough milk going through the baby's intestines, then more of that bilirubin is going to get reabsorbed that the baby then has to deal with. The second thing is called breast milk jaundice, and this essentially has to do with a specific enzyme in breast milk that makes it so that there's more recirculation or more absorption of that bilirubin as well. Okay, so 80% of kids have jaundice. For most of them, it's not a problem, but how do we test and make sure that we don't miss the ones where there is a problem, where the levels are actually higher than we think? Well, the extent of jaundice or the extent of yellowing is really not a reliable way to know the exact level in a patient's blood. So in the early 2000s in the United States, we began doing universal bilirubin screening. So this means even for full-term healthy kids, before they go home at 24 or 48 hours, we will check a level of bilirubin in the blood to know if it's too high and needs treatment, if it's low and normal, or if it's high and needs close follow-up. This testing can be done either transcutaneously, which means through the skin, or by getting a serum blood value. Transcutaneous or through the skin should be fine, but it's not quite as accurate as the blood level itself. So how do pediatricians think about this? Well, basically, they have these things called nomograms. So as a pediatrician, I would say, okay, how old is the patient? Let's say 3 days old when I get this bilirubin test. I would then graph out the level of bilirubin in the blood and use these lines based on what gestational age the patient is to decide whether they need a phototherapy treatment or not. This is just showing that thought process which I just described, but basically if the bilirubin level is above what was shown on the graph, then the patient will need treatment with phototherapy, and if it's below but still elevated, then there are other guidelines that will tell me as a pediatrician of when does this patient need to follow up, within 24 hours, 48 hours, 72 hours, or whatever. We said, okay, a lot of kids have jaundice, some have severe high levels of bilirubin, and what we're really trying to prevent is that deposit of bilirubin into the brain, which can cause kernicterus and bad outcomes for children. So it really does cause bad brain damage. If the levels are pretty low, the patient doesn't need phototherapy, so we're down below that treatment threshold. What we often encourage is just make sure that the kid is feeding. So breastfeed as frequently as possible and make sure the child's having nice urine output and good stools. If during this period the child's really not latching, you're not getting anything in, there's reduced wet diapers or reduced stooling, you would want to follow up with your pediatrician earlier. Because like we talked about before, having that gut functioning, getting poop into it and out of it is really helpful to prevent reabsorption of the bilirubin, which could be a problem for the baby. So if the feeding frequently didn't work and the level is actually over our phototherapy treatment level, then you have to usually come into the hospital, sometimes outpatient, but get treated with a phototherapy light. This is a blue light that essentially takes the bilirubin and breaks it down into a substance that the baby can excrete or get rid of more easily. When you're receiving phototherapy, we really want the baby as stripped down as possible. So maybe a diaper, definitely some eye shades, but otherwise as much skin exposure to those lights as possible. And we really want them on for more than 18 or 20 hours a day to really get control of the levels. In the past, you may have heard, and there's some truth to this, that sunlight can reduce the levels of bilirubin in the blood. And that's true, but the strong recommendation would be that if your child has jaundice, just follow the pediatrician's advice and follow up what those levels mean. If they're low and the jaundice isn't a clinical concern, then you really shouldn't do the sun exposure for no reason. And if they're high and require treatment, then you really want to do the effective thing, which is phototherapy. Okay, so you try feeding, you try phototherapy. The last thing we can do is, if it's needed, you can actually do what's called an exchange transfusion, where you actually take out the bad blood from the baby and put in good blood that has lower levels of bilirubin to help them out and prevent kernicterus. It's pretty rare that this is required, but it is sort of like the fail-safe treatment if needed. I put these things up here just as warnings. You know, if you're in one of these periods where the pediatrician says, hey, the level's not so bad, why don't you come back in a little bit? Just remember, if there's a fever, if the jaundice gets a lot worse, if there's difficulty breastfeeding, sucking, swallowing, not peeing as much, not pooping as much, and then any sort of neurologic signs, so abnormal cry, not waking up, difficult to console, weird arching or tensing of the body, or difficulty or change in breathing pattern would all be reasons to go back to your pediatrician. The only other thing I'm going to say is if your baby has jaundice at more than 2 weeks of life, or especially like out towards 4 weeks of life, I would strongly recommend going back to your pediatrician and trying to get a blood test to look at what type of bilirubin is in the blood. And the reason for this is just that it's incredibly rare. Only about 500 kids a year in the United States have this, but if your liver is not able to get rid of bilirubin, it can sometimes be a sign that a child has what's called biliary atresia, where the duct or the tube that normally transmits that bilirubin never forms appropriately, and there's actually a critical surgery that needs to happen to prevent liver failure, which would require a liver transplant. So that's it for the video. I hope as always it was helpful. If it was, please like, subscribe, and share, or otherwise just leave a comment, let me know what you thought. Thanks so much.